this video, we will be discussing a medical condition known as peptic ulcer disease. We will go through the relevant anatomy of this case, the pathophysiology, diagnosis, treatment, complications and prognosis, and discuss how widespread this is in the world. Let's begin with the clinical case.
Good afternoon, ma'am. Mag-take care ko si mong BP, ha?
May hapon, ma'am.
Hi, Doc.
Ano nagpakonsulta ka karon, ma'am?
Sakit mo good kayo, dapat diri sa untiyan, Doc. Sa mga ni-ari na nagid ko, kay sakit nagid kaayo.
Kano sa man ni nagsugod imong sakit sa tiyan, ma'am?
Mo balik-balik pa gyud siya to 4 weeks, so mo nang ni-ari na lang gid ko, Doc. Ay, sakit na dyan ko, Doc.
Pwede ni mo matudlo, ma'am, asa dapit ang sakit?
Diri, Doc, ay sakit gid kay, Doc.
Pwede ni mo ma-rate from 1, biling di kaayo kasakit, 10, pinakasakit jud.
Mga 10 madud guro, Doc, kay sakit gid siya, Doc. Like kanang gay murag gitusok-tusok akong diri, sakit gid kaayo.
The doctor may also ask if you smoke, drink alcoholic beverages, or skip meals. So what does the patient mean? In order to make things clearer, we have to know first the relevant anatomy related to this case, specifically the esophagus, stomach, and duodenum. Distal esophagus. The esophagus is a 25 centimeter long muscular tube that conveys food from the pharynx to the stomach. It has 3 distinct constrictions, marking the different regions: the cervical, thoracic or bronchoaortic, and diaphragmatic constriction. The diaphragmatic region is also characterized by the esophagogastric junction. In this junction, a Z-line is found where the mucosa abruptly changes from esophageal mucosa or stratified squamous epithelia to gastric mucosa or simple columnar epithelia. The superior third or external layer is made up of voluntary striated muscle. The middle third is made up of both voluntary striated and smooth muscle. Lastly, the inferior third is made up of smooth muscle. The esophagus terminates by entering the stomach at the cardiac orifice of the stomach to the left of the midline at the level of the 7th left costal cartilage and T11 vertebra. Stomach. The stomach is the expanded part of the digestive tract between the esophagus and small intestine. Location of the stomach changes depending on diaphragmatic movements from respiration, the stomach's contents, empty versus full, and the position of the person. In the supine position, the stomach lies in the epigastric, umbilical, and left hypochondrium and flank regions. It has 4 parts: the cardia, fundus, body, and pylorus. The body is the major part of the stomach, containing gastric folds or rugae. The stomach is capable of expanding to accommodate 2 to 3 liters of food. Duodenum. The duodenum is the first and shortest part of the small intestine with a length of 25 centimeters. Its C-shaped course around the head of the pancreas starts at the duodenal bulb and ends at the ligament of Treitz. It is composed of 4 distinct parts. The first is the superior part, which lies anterolateral to the L1 vertebra. The proximal part immediately distal to the pylorus has a mesentery and is mobile. Its distal part and the remaining parts of the duodenum have no mesentery and are immobile. The second part is the descending portion that descends along the right side of the L1 to L3 vertebrae. The ampulla of Vater, where pancreatic and bile ducts release their secretions, can be found here. The third is the inferior part that crosses the L3 vertebra. The fourth ascending part arises at the left of L3 to as far as the superior border of L2. As for its blood supply, the superior and inferior pancreatico-duodenal artery supplies its upper and lower halves respectively. The vein of the duodenum include the superior and inferior pancreatico-duodenal vein, which drain into the portal vein and the superior mesenteric vein respectively. Its innervation is derived from the sympathetic and parasympathetic vagus nerves of the celiac and superior mesenteric plexuses.
Ma'am, naabay particular na butang or oras nga mas mo grabe jud ang sakit?
Sa akong nabantayan, Dok, kay marag musuol raman siya, Dok. Like, after na akong kaon, like, masakit gid kay siya. Like, masamot ang tusok-tusok.
Ikaw pala man nahitabo imong pagsuka, ma'am.
Kato raman siguro ka isa, Dok.
Pwede nimo ma-describe imong itsura sa suka nimo, ma'am?
Sa akong nabantayan na to before, Dok, like, pagsuka na ako kay... Ito man to ako suka, Dok, niya na ay mga tibugol.
Pathophysiology. In the upper gastrointestinal tract, there is a balance between mucosal insults and mucosal defenses. If there is an imbalance, an ulcer can form. Gastric acid is made by parietal cells in the stomach. There are 3 types of receptors on the parietal cell which stimulate production of acid: gastrin, acetylcholine, and histamine. Gastric acid production is inhibited by somatostatin and prostaglandins. Defenses include a mucus and bicarbonate layer, an epithelial barrier, and adequate blood flow. Ulcers develop when this balance is changed. Prostaglandin deficiency can lead to the formation of ulcers. Cyclooxygenase types 1 and 2, or COX-1 and COX-2, are responsible for the production of prostaglandins. NSAIDs are known to lead to a deficiency of prostaglandin production through inhibiting COX-1 and/or COX-2. This then allows for enhanced gastric motility, increased mucosal permeability, infiltration of neutrophils, and the production of oxyradicals. This eventually leads to the formation of gastric lesions and ulceration. Although H. pylori has been proven to cause peptic ulcer disease, the mechanism is not completely understood. It may be the result of a direct effect on the parietal cell, causing an increased production of gastrin, or through an indirect mechanism secondary to inflammation and the production of cytokines. Other drugs may cause ulcers, including methamphetamines and cocaine. It is presumed to be secondary to restricted blood flow and ischemia in the stomach. So what could be the possible disease or illness of the patient? Diagnosis. The doctor may inquire about your medical history and symptoms, conduct a physical exam, and order tests to diagnose and determine the cause of a peptic ulcer, as well as to detect any complications. The physical exam usually involves checking for abdominal swelling, listening for sounds with a stethoscope, and assessing for tenderness or pain through abdominal taps. What tests do doctors use to diagnose peptic ulcers? Doctors use blood tests and a urea breath test to diagnose peptic ulcers. Blood tests check for signs of H. pylori infection or complications of peptic ulcers. The urea breath test involves swallowing labeled urea and exhaling into a container. Detection of carbon dioxide confirms an H. pylori infection in your digestive tract. The stool antigen test is a common test to detect H. pylori in stool samples by looking for associated proteins. The stool PCR test can identify mutations and resistance to antibiotics used to treat H. pylori, but may not be available at all medical centers and is more expensive than the stool antigen test. During an upper gastrointestinal endoscopy, a doctor uses an endoscope with a camera to see your upper gastrointestinal tract and take small tissue samples from your stomach lining using an instrument passed through the endoscope. A pathologist then examines the tissue under a microscope. The upper GI series examination, also known as a barium swallow, uses X-rays to create images of your upper digestive system, including your esophagus, stomach, and small intestine. To make an ulcer more visible, you will swallow a white liquid containing barium during the X-ray.
Okay ra nimo, ma'am, kay magpakuha tag X-ray o CBC para mas makatarong tag pili unsay mas maayo nga treatment sa imong kondisyon ron, ha?
Sige, Dok. Okay ra, Dok.
Sige, salamat, ma'am. Ma'am, naanad ay namo imong lab results. Based sa findings, ma'am, naa kay perforating gastric ulcer.
Based sa X-ray, ma'am, naihangin ubos sa duha nimo ka hemidiaphragm.
Diri sa imong tiyan dapat kay nay buslot nag-perforate na gyud ba? Sa imong CBC ma'am, taas imong WBC. Nya if taas imong WBC count, meaning ani kay nay infection nga nahitabo sa imong kanang kalawasan ron.
So unsa may angay buhaton na Dok?
Since ni perforate naman jud imong ulcer ma'am, kailangan na jud ni nato operahan.
So why does the doctor advise the patient to do the surgery? Treatment. The goal of treatment for peptic ulcer disease is to relieve symptoms, heal lesions, prevent recurrences, and prevent further complications. Patients with mild to moderate symptoms of peptic ulcer disease are advised to take medications that inhibit secretions, such as histamine receptor blockers and proton pump inhibitors, or PPIs. Recently, PPIs are more favored due to their superior healing and efficacy, as they block acid production in the stomach and relieve the symptoms while promoting healing. Medications may be taken along with calcium supplements, as long-term use of PPIs can increase the risk of bone fractures. For NSAIDs-induced peptic ulcer disease, NSAID medication and the following drugs are discontinued if possible. For H. pylori-induced peptic ulcer disease, a triple regimen comprising of 2 antibiotics and a PPI is used as first-line treatment. Medications administered include the following and are used for 7 to 14 days. If first-line therapy fails, quadruple therapy with bismuth and different antibiotics is used. For patients with severe symptoms, such as those with refractory peptic ulcer, who are unresponsive to medical treatment, non-compliant, or at high risk for complications, surgery is advised, such as vagotomy or partial gastrectomy. If the patient refuses to do the surgery, what would likely happen? Complications and prognosis. If left untreated, peptic ulcers can lead to various complications, and internal bleeding resulting to anemia can occur. Additionally, a peptic ulcer can create a perforation in the stomach or small intestine, risking the development of peritonitis, a serious abdominal infection. Prevention of the reappearance of ulcers is important, as well as treating the disease itself. Unfortunately, recurrence is prevalent. Nonetheless, mortality rates associated with peptic ulcer disease have significantly declined compared to previous times.
May buntag, ma'am. Musta naman imong pamati, ma'am?
Mas ni okay na noon karon Dok. Common ba na siya na kondisyon Dok?
Oo, ma'am. Common ra gyud ni siya nga kondisyon.
Do you think what the doctor is saying is true? Let's find out based on numbers. Epidemiology. Studies have shown that peptic ulcer disease is a global problem, with a lifetime risk of development ranging from 5% to 10%. However, there has been a decrease in the incidence of peptic ulcer disease worldwide due to improved hygienic and sanitary conditions combined with effective treatment and judicious use of NSAIDs. The occurrence of peptic ulcer disease can be narrowed down into 2 common causes: Helicobacter pylori associated and NSAID associated. H. pylorus bacterium is responsible for 90% of duodenal ulcers and 70% to 90% of gastric ulcers. H. pylori infection is more prevalent among those with lower socioeconomic status and is commonly acquired during childhood. NSAID drug use is the second most common cause of peptic ulcer disease.
Ma'am, wala ra tay laing gibati pod.
Wala raman Dok.
Wala ra tay dugang pangutana, ma'am.
Wala ra po Dok. Thank you Dok.
Way sa pa yan, ma'am.